Good evening, dear doctors. I'm Dr. Harshveer Singh Mali, lead for medical affairs for oncology at Merck India, and it's a privilege to welcome you all for today's Med Science meeting. The Med Science meeting is thought about from a collaboration amongst HCPs to discuss for med altered non-small cell lung cancer patients and the evolving landscape for management of these patients. So it will encompass both MET-X14 and MET amplifications in this subgroup of patients. For today's meeting, we have a very interesting agenda lined up. Of course, it will be led by none other than Dr. Shyam Aggarwal sir, who is chairing this session. We also have Professor Sanjay Popat sir joining us from UK as the expert faculty for today's session. We'll also have a couple of moderated sessions led by Dr. Jyoti Wadhwa ma'am and Dr. Ullas Batra sir, respectively, for their sessions. Without further ado, of course, I will hand over this session to Dr. Shyam Aggarwal sir, who actually needs no introduction. But just for formality, sir is the chairperson for medical oncology at Sir Gangaram Hospital, New Delhi. He has been a doyen in medical oncology and has also numerously guided us for newer therapies and for important educational events for medical oncologists and oncologists throughout the country and also for the region. Shyam sir, it is our privilege to have you for today's session as the chairperson, and may I please invite you for your opening remarks.
So good evening, everyone, and thank you, Dr. Harshveer, for those kind words. Thanks to Merck for setting up this webinar with Dr. Sanjay Popat being the lead speaker, and as you introduced, a couple of panel discussions here. So basically, the whole objective is to dwell into the MET gene, which is abnormal in patients with non-small cell lung cancer. And the couple of types of abnormalities, one is, of course, the MET exon 14 skipping mutation, which occurs in about 3 to 4% of NSCLCs. And the MET amplification in NSCLC occurs in around 1 to 6%. So both have their own implications because we do have agents which have now become available for these targets, particularly for the MET exon 14 skipping mutation. So interestingly, the incidence for this is high in sarcomatoid kind of lung cancer, but it does occur in adenosquamous, about 6%, and in squamous and adenocarcinoma. So it's very interesting to see that the receptor for the MET, basically the 13 and the 14 exon come together, which results basically in the impairment of the receptor downgradation, and as a result of which the MET signaling is enhanced, and therefore the tumor cells survive. So I think we're going to be learning more and more about this from our international speaker. And as if you go back and look back, say 30 years ago, the lung cancer or non-small cell lung cancer used to be just one disease. And now, of course, with the understanding of gene sequencing and comprehensive gene sequencing, or CJP, and the understanding of also including the RNA, we are able to pick up such uncommon and rare mutations in patients with non-small cell lung cancer, making it so heterogeneous, almost 14 to 15 types of uncommon abnormalities or aberrations which we can target today are available. So I think this understanding for identifying targets and then to develop agents which can stop these onco drivers or oncogenes which are driving the tumor cell. This science has really evolved. And I think the only constant thing as we see is the change which is happening in patients with non-small cell lung cancer. And just on the lighter side, since Dr. Sanjay is going to speak next, so we are seeing a huge change in the politics of United Kingdom as I speak here. The conservatives are going out, and the other party is coming in. So I think change is the only constant thing in life, and that basically helps us to evolve into better understanding and targeting these mutations. Of course, you do have the immune oncology drugs which are playing a role in patients who have no targetable mutation. So the whole non-small cell lung cancer game has opened up for the benefit of the patients, and the understanding of the molecular biology has tremendously helped them in guiding us in taking decisions on an individual patient. So I think with this background, I think we need to move on to the first talk, which is going to be delivered by Dr. Sanjay Popat. And he is the professor consultant, thoracic medical oncologist at the Royal Marsden Hospital. And he's professor of thoracic oncology at the Institute of Cancer Research. He's been instrumental in designing clinical trials, identifying DNA variants that influence thoracic cancer development, and developing, identifying biomarkers which are predictive of therapeutic benefit. And as you can see here, he's a member of several organizations, including EORTC, ETOP, CSG, BTOG, and CRN. So, I mean, we've heard him before. He has visited India. I think we're going to be gaining a lot through his two talks. The first focusing on the exon 14 skipping mutation. So over to you, Professor Sanjay. Look forward to it.
Great. Thank you, Dr. Aggarwal, for that very kind introduction. And as you point out, there is only one constant in life, and that is change. And we certainly know that's true in politics, and it's definitely true in biology. And today we're talking about MET. Who knows what we're going to be talking about in the next few weeks, the next few months. So I'm just going to share my screen, and tell me when that is coming through, and confirm that you can hear me and see me okay.
So we can see your screen. Wait.
Great, thank you. So I've been asked really to speak to you about how we manage our patients with MET exon 14 mutations, and these are my disclosures. So, as we heard before, lung cancer, specifically non-small cell lung cancer, is really a heterogeneous group of disorders. And when we do genotyping for routine clinical care, there are at least 11 different molecular classes of mutations we need to look at for approved licensed therapeutics. If you add in unlicensed therapeutics, there are many more. But really, our molecular genotyping really has to be very robust now. And this is the list of drugs that we have for FDA-approved treatments, EMA-approved treatments, and of course, Britain is now out of EMA. We have our own regulatory environment, which is sort of halfway house between the two, FDA and EMA. And for the purposes of today and my talk now, MET exon 14 does have two approved drugs for use, capmatinib and tepotinib. So I'm going to spend some time telling you about the biology, about these types of tumors, and the data to support the different types of therapeutics that we have for these tumors. So the first thing I want you to understand is a bit of basic biology, which is that chromosome 7 is incredibly important in lung cancer. And why is it important? Because we've got these 4 critical driver genes on chromosome 7. We've got EGFR, short on chromosome 7, 7p. And on 7q, we've got 3 really important driver genes, CDK6, MET, and BRAF. And it's really important that you know that these are on the same chromosome and that these are drivers. I'll come back to that in the second talk about MET amplification. Now, we're talking about MET14, but you can't talk about MET14 unless you talk about the whole MET system. And we have to recognize there are at least, I would say, 4 major categories of MET abnormalities that drive carcinogenesis in lung cancer. So first of all, you have on the left-hand side normal MET signaling. So MET is a receptor, a tyrosine kinase. It's a transmembrane receptor like EGFR. And it has a kinase domain intracellularly. And it's got something called the juxtamembrane domain, which is encoded by exon 14, which binds to something called CBL, CBL. And that relationship between CBL and MET keeps that under control. When those two are not in a good relationship, a bit like a marriage dissolving, then the whole thing blows up, like a divorce. And that's what happens with exon 14 skipping mutations, which is the next panel. Because when you have a mutation which eradicates exon 14, then CBL cannot bind. And that results in stabilization of MET, which causes more signaling through the cell receptor from the outside milieu, where it binds hepatocyte growth factor into the intracellular domain, resulting in transformation of the cell. But that's not the only genetic abnormality we see. We also see mutations within the kinase domain. And if you follow my Twitter account, I'll have tweeted about this week. This is a very nice paper in Cancer Discovery describing these MET kinase domain mutations in multiple cancer types, including non-small cell lung cancer. And this is the same sort of thing that you see with, for example, EGFR L858R, point mutations which switch on the kinase domain. These are extremely rare. And for the purposes of today's talk, we're going to talk about MET14 and the other abnormality called MET amplification. And what happens with MET amplification, you have many copies of the MET gene, which result in many different receptor molecules, which may result in more protein, MET protein expressed at the cell surface. And the more the gene is amplified, the more it's expressed, the more it signals. And it's a bit like HER2 amplification. It causes carcinogenesis through that way. And in the extreme right, we have this other abnormality called MET fusions. And this is where the MET kinase domain fuses with other genes. And there's a variety of these that have been reported. Extremely, extremely rare to find these, but you can find these. And these result in, again, signaling. And I guess the similar thing that you might expect would be something like ALK fusions or RET fusions. Exactly the same type of biology. So why is this important? Well, we've got to identify the MET abnormality. And I always say to the residents, telling me that the cancer is MET positive is completely hopeless. Please stop doing that, because you are not telling me what the problem is. Is the problem MET14 mutations or a MET exon 14 skipping mutation? Is the problem MET amplification or copy number gain? Or is it overexpression? Because the three are potentially distinct, but they all overlap. Because you can have patients with MET exon 14 mutations who have MET overexpression, but may not have amplification, or they may have all three. And there's a lot of overlap between here, and I haven't talked about mutations and fusions in this particular panel. So we have to be very precise when we're talking about what particular abnormality we're talking about when it comes to MET. Now, what we're talking about here today is MET exon 14 skipping mutations. When I heard the term, I thought, what is this? The gene is skipping with a skipping rope? Doesn't make any sense, right? So actually, the true molecular nomenclature, the Human Genome Variation Society nomenclature, HGVS nomenclature, is something called splice site mutations. Because in a gene, what we have on the screen here is we have the coding regions of the gene called the exons, exon 13, 14, 15, and you have the non-coding regions. These are called the introns. Now, what we have in the setting of MET14 is you have mutations which either occur in the introns, for example, in the top line, or at the intron exon boundary, which is in the bottom, in the middle line. I don't know if you can see my mouse. And what that means is that if you have a mutation, certain types of mutations, either in the intron or in the intron exon boundary, that mutation means that when the DNA is then transcribed into an mRNA, which you can see here at the bottom, exon 14 is missing. So if you were then sequencing the RNA, you would see the sequence for exon 13, and then suddenly you would skip right into exon 15. Where's exon 14 gone? There's nothing there. So exon 14 is skipped out. It's called a splice site mutation. And this is really important because you can see where the X's are on this figure. The mutations are not within the exons by and large. They're often within the introns or the intron exon boundary. So if you're using DNA sequencing, your DNA sequence panel may not be able to pick these up. And you're therefore far more likely to pick these up if you're using RNA sequencing, because your RNA will sequence the mRNA species, the cDNA, and it will say, hang on, I've got the exon 13 sequence, and then I'm suddenly skipping right across to exon 15. It's much better found on RNA NGS because of deficiencies in coverage by the DNA panels that we generally use. So how are we going to find these abnormalities? Well, look, it depends on what test you're using. And this is why we have to have some form of comprehensive testing. And this slide is taken from the Met Crusaders patient website. This is my table. So if you're using DNA NGS, it's very good for DNA. So it might detect some MET exon skipping mutations. It will definitely detect the kinase mutations. It's not very good at detecting amplification, and it probably is not very good at MET fusions. ctDNA is the same as DNA NGS, so it has the same properties, assuming you're shedding enough into your plasma, as I've lectured about before. Now, if you're using RNA NGS, you'll probably detect nearly all of the exon 14 skipping mutations, and you'll detect some of the kinase domain mutations depending on what the technology is configured to do. But you won't detect the copy number gain, the amplification necessarily, and you will detect some of the fusions. We often use MET-FISH, which I'll talk about in the future as well. It won't detect MET exon 14 mutations, won't detect kinase domain mutations, will detect amplification, and won't detect fusions, because FISH is looking for structural abnormalities, not sequencing abnormalities. Immunohistochemistry, our good old friend, won't detect MET exon 14 mutations, won't detect kinase domain mutations, but may detect, and it's a may detect amplification, which causes overexpression, but not all amplification causes overexpression, and won't detect MET fusions. So which test are you using? Because which test you use will determine what your test can pick up. And I would suggest it's very useful to have both DNA and RNA NGS, and often in certain circumstances, I will also request MET-FISH, and we may be moving over to MET-IHC in the future as well. So who are these patients with MET exon 14 mutations? Well, the first data set came from the US, and one of the initial data sets came from my colleague Popat and colleagues who were at the Memorial Sloan Kettering Cancer Center, and they described 8 patients from their MSKCC impact data set who had splice site mutations which resulted in abnormal splicing of exon 14 in MET for it to be removed. And these 8 patients are classical for what we see. So let's look at them. They're not young. They're relatively senior, age 73, 80, 79, 80, 80, 90, 86. These are senior patients. There is a equal relationship in gender between males and females. But here's what's really interesting. They tend to have some smoking history. Now, you can see these in never smokers, but often these patients have often smoked. Now, is this because these patients were smoking in their teenage years, which was, often 80 years ago, in a very different environment to how it is now, or is it completely different? And the other thing that we recognize is we see these in good old-fashioned adenocarcinoma, but we also see these in carcinosarcomas, otherwise known as pleomorphic tumors. and in the pleomorphic subtype of non-small cell lung cancer, which we know is a highly aggressive type of disease. There's a good data set now to show that it's a founding event, which is a unique event, and then the cells differentiate into both the, for example, fold cell or spindle cell variant and the adenocarcinoma to make it a mixed pleomorphic type of tumor. So how should we be treating these patients? So we first started treating these patients with crizotinib back in the day. And those of you that have been in thoracic oncology for a while will know that crizotinib was actually designed as a MET inhibitor. PF02341066 was designed as a MET inhibitor before it was identified to be active, and ROS and ALK was identified as the target. So there are many data sets using crizotinib in MET14 non-small cell lung cancer. This is one data set. This is the UK National Lung Matrix trial, which is basically a basket trial. I led cohort D, which is the crizotinib arm, in which patients with a variety of MET abnormalities or ROS fusions were given crizotinib. And you can see here that crizotinib has activity. In MET exon 14 at the bottom, it has a median PFS of around 1 year, disease control rate of about 68%, and response rates of about 65%. Not bad, but we know that crizotinib is not really a selective MET inhibitor, and we know that it has its challenges with intracranial control. So can we do better? So we now have 3 approved drugs, depending on which jurisdiction you're in, which are MET selective inhibitors. In Europe and in the FDA jurisdiction, we have tepotinib and capmatinib, and in China, they have savolitinib. The rest of the world, savolitinib is still in development. So let's focus on tepotinib and capmatinib. These are highly specific MET-directed inhibitors with very strong IC50s against MET. They have very good response rates. They have very strong intracranial progression. Tepotinib is given as 2 tablets a day at 450 milligrams once daily, and there's a 1-step dose reduction schedule. And I'll come on to some of the data shortly. The main data set that supports the use of tepotinib is the VISION study, which is a single-arm phase 2, really quite a large study actually, in patients with MET14 mutations, which occurred right the way before the COVID pandemic, through the COVID pandemic, and towards the end of the COVID pandemic as well. And this was composed of 3 cohorts. The cohort A, which is the primary analysis for regulatory submission, of 152 patients, a confirmatory analysis cohort, cohort C, 161 patients. That was pooled for the regulatory approval in some jurisdictions, 300 patients, and that can be divided into 164 patients who are treatment naive, so metastatic de novo presentations, and previously treated, about 150 patients as well. This is a typical registrational phase 2 cohort requiring PS0, 1 patients with measurable disease with the primary endpoint of response rate to go in. Now, who are these patients? As I've said before, these are our senior patients. So median age was not 65, 60 like we tend to see in many other trials, but was 74. A relatively equal split between males and females. And here's really interesting. Around half the patients had a smoking history. Only 45 to 50% of patients had never smoked. As we've discussed, the vast majority of patients, 80% of patients, were adenocarcinoma, but other patients were otherwise not otherwise specified or pleomorphic. And this trial was great because it was one of the first trials that utilized ctDNA to enroll into the study because of the problems that we have in identifying MET14. It's not an easy mutation to identify. So this enrolled patients, the vast majority, about 65% of patients, had tissue biopsy confirmed MET14, but around half of them had also ctDNA confirmed, and some of them had only ctDNA confirmed MET14. And what we see here is that in the bottom, the response rate is high. It's about 60% of patients, and it's rapid. So even though the response rate is only 60%, actually shrinkage occurs in the vast majority of patients, regardless of treatment. The duration of response is high, 46 months of duration of response. You can see that's drawn out because of a number of sets of events, but still, nevertheless, the duration of response is high, and the progression-free survival is what you'd expect for a druggable oncogene with a receptor tyrosine kinase abnormality, 16 months, leading to an overall survival of nearly 2.5 years, nearly 3 years, 29.7 months for our fit patients in this study. Now, this was one of the first studies that demonstrated the prognostic impact of ctDNA, because whilst we can see in the combined data set that the median PFS was 8.6, this is both second line and first line combined, what you can see is that those with tissue biopsy in the dark blue had better PFS than those with the light blue, the liquid biopsy who did poorer. So we can clearly see that ctDNA detected patients are prognostic. And you can see that in the response rates on the right-hand side as well, because those patients with liquid biopsy had slightly lower response rates compared to those patients with tissue biopsy-proven disease as well. Well, what about CNS, right? So these patients have a propensity to CNS metastases. And indeed, this was evaluated in the confirmatory cohorts A and C, evaluated using RANO-BM analysis. We know that tepotinib is very strongly active in the CNS. It crosses the blood-brain barrier. It's very similar to other drugs like your RET inhibitors and your ALK inhibitors. And indeed, in cohorts A and C, 43 patients had brain metastases that were evaluable by RANO-BM. Around 70% of patients had some form of brain radiotherapy or surgery. And in patients with target or non-target lesions, the intracranial response rate was 88%, with the intracranial median progression-free survival of 20 months. That's very high. But here's the really important thing. In 15 patients, so not a large number of patients, you can see them on the waterfall plot on the right, 15 patients with target lesions, so these are patients with untreated brain metastases, the intracranial response rate was 66%, with the intracranial duration of response not reached. So this is a very, very strong data set indicating and confirming intracranial control. So these patients, by and large, they don't need SRS. You identify them, put them on tepotinib, and there you go, the brain lesions settle down, as you would with any other CNS penetrant oncogenic driver mutation. So look, what do guidelines say? ESMO clinical practice guidelines, they recommend you look for exon 14 up front. If you do it, you have the option of using platinum doublet chemotherapy or a MET selective inhibitor, tepotinib or capmatinib. Why on earth you'd use chemotherapy with or without IO, I have no idea. But the reason that it's there is because in Europe, the European label is not frontline. That's because Europe are really very strong governance. Whereas in the UK and in the Orbis countries, that's the FDA jurisdiction countries, we have first-line approval to use it, which is why the strength of evidence is 3A for tepotinib, because it's not a randomized phase 3 trial. It's only a single-arm trial because of the rarity of this population. It makes no sense, I would suggest, to do a randomized phase 3 trial. And of course, if you're not giving it first line, I mean, who knows why you wouldn't give it first line? You can give it second line if you wish. So look, safety issues. We have to be a bit concerned about some of the adverse events we see with MET inhibitors. And both the selective MET inhibitors, capmatinib and tepotinib, both have very similar adverse events. We see fluid accumulation in third spaces. So we see pleural effusions, we see peripheral edema, we see hypoalbuminemia, and we see increased creatinine because tepotinib and capmatinib block MATE, which results in the serum creatinine being artificially elevated. It's not true renal impairment. We also see GI disturbances with low rates of nausea and diarrhea, and ALT rise as well. Now, the hypoalbuminemia is not because patients develop nephrotic syndrome. They're not losing it in the urine. They're not losing it in the stool. They don't develop colitis. This is a central inhibition of albumin production, which occurs several months into the duration of therapy, which then causes the third space fluid accumulation, peripheral edema, and the pleural effusion that we can talk about its management later if needed. Now, here's the toxicity summary of the adverse events seen with tepotinib, capmatinib, and savolitinib, really very, very similar in terms of the third space collections in terms of edema, which is one of the more problematic toxicities that we have with this class of agents. Now, Merck wanted me to put this in the slide deck. They have done a indirect analysis of activity of tepotinib versus capmatinib, and there's a suggestion that tepotinib does have a superior efficacy compared to the capmatinib data based on geometry, but this is a indirect meta-analysis which, as we know, has issues and is not as superior as we would suggest with a direct head-to-head study. But of course, it's impossible to do this, so we have to go by these indirect comparisons that we have. So you're going to say, yeah, Popat, well done, right? That's all very good, right? But it's easy if I just use pembrolizumab up front. The pathologist has told me PD-L1 90%, the NGSER is going to take 8 weeks to come through. Who's got time for that? I've got the family breathing down my neck. I can put them in to get pembro tomorrow, right? Why don't I just do the pembro tomorrow? The answer is that is the wrong treatment for the patient. Why is it the wrong treatment for the patient? So biologically, there is no rationale for giving. So on the top left-hand side, you can see that the TMB in MET14 patients is always lower than in patients without TMB. In the bottom left, there is no relationship between TMB and PD-L1 levels. So the PD-L1 level seems to be reactive rather than a driver or indicator of the tumor inflammatory microenvironment. And this is a retrospective study through a number of centers in the US, led by colleagues at Memorial Sloan Kettering. My colleague Josh Sabari presented this at ASCO 2018, and then subsequently published in the Annals of Oncology. And you can see this is the frontline experience with pembro. Most patients progress. Response rate, 17%. Median progression-free survival, 1.9 months. And you can see in the table above, even those patients in green with very high PD-L1s, by and large, do not benefit. So yeah, use pembro, but use it second line, right, or third line. These patients, really first line, MET inhibitor is what you really need to be giving them. So does it work, right? So there's a couple of cases. This is one of the first patients we treated. She was actually presented as corona hit us in March 2020. We couldn't do any biopsies. She had that PET scan. She's got the primary small tumor in the top left. We've got tumor threatening the cord in the thoracic vertebra in the middle panel, and we've got an iliac blade metastasis, ctDNA, confirmed MET14. We had to wait a while to give her tepotinib, but clearly it was the right thing to do. She had a fantastic response. This is the second scan that we actually know, the first scan on the right-hand side, August 2020, a superb metabolic partial response. This is an elderly lady, right, in her 80s, and would have had all sorts of trouble with any form of other systemic therapy. We know that pembro wouldn't have worked full well. She had a good duration of response for a year. And, really, really very, very pleasing just to give her that and see her as an outpatient. She had a few issues with hyperalbuminemia and pedal edema, which we addressed, but actually superb quality of life with tepotinib. This is the patient I'm treating at the moment, 76-year-old ex-smoker, metastatic TTF1 adenocarcinoma, PD-L1 2%. He had ctDNA at the time of diagnosis, non-evaluable. He had EBUS. It wasn't suitable for NGS. In the end, he actually had a bone marrow biopsy, which confirmed MET C.292-1 G2A. So what does that mean? That means in the cDNA, in codon 292, at the intron exon boundary, at one base pair proximal to that, the G nucleotide is changing to the A nucleotide. So when you see that minus number or the plus number, it tells you it's at the intron exon boundary. And so this is a MET14 splice site mutation. put straight on the first line tepotinib. Absolutely a complete response. He's back to normal, living a normal life. He's starting to develop problems really with peripheral edema. And you can see in the right-hand panel by October 23, he's now got some oligoprogression. And those of you with very beady eyes will see small volume bilateral pleural effusions, which are nothing to do with a tumor, and they're due to fluid retention from his tepotinib. And so in conclusion, MET14 identification is critical for first-line decision therapy making in routine clinical practice, and I would suggest that tepotinib is indicated for first-line patients as supported by regulatory approval with very high response rates, durable response, high intracranial activity. PD-L1 is not predictive of benefit to IO, and IO is not the preferred therapy for these patients. Selective MET inhibitors are very classical, and they are characterized by their peripheral edema and aberrantly elevated creatinine. So please, when you see that creatinine going up, it's nothing to do with renal failure. It's just an aberrant rise because of MATE inhibition, because of the drug binding. And with that, I'll stop sharing and thank you for your attention.
Thank you so much, Professor Sanjay, for that great session on METX14 and the management of the patients. With that, I will also take this opportunity to move further. Of course, the next session is the panel discussion, which will be led by Dr. Jyoti Wadhwa, ma'am. And in this panel discussion, we'll have Dr. Nandini Menon joining us, Dr. Ullas Batra also joining us, Dr. Anup, and of course, Professor Sanjay, we will also request your participation in the panel discussion. Himanshi, if we can go to the next slide, please. And the intro slide for Dr. Jyoti Wadhwa, ma'am. Yes, Dr. Jyoti Wadhwa, ma'am, is the Vice Chairperson and the HOD for Medical Oncology and Hematology at Paras Health Hospital in New Delhi. Ma'am, it's a privilege to have you moderating this session, and may I please invite you for your moderator session.
Thank you, Harshveer, and thank you, Mark. I would display my slides myself, so if I could be allowed to share my screen.
Yes, ma'am, you can, please. Thank you. Ma'am, we can see your slides.
So thank you, Professor Sanjay. That was a very comprehensive and crisp talk, talking about MET exon 14 skipping mutation. And I'm sure the panelists will have an easy job. So the aim of this first panel discussion is basically to highlight the importance of testing for MET exon 14 skipping mutation in patients with advanced non-small cell lung cancer. And also we would request the panelists to share their practical insights as regards the management of this subset of patients. So as already highlighted, we are treating patients with non-small cell lung cancer as per the biomarkers that are driving the cell replication, and MET exon 14 skipping mutations do constitute an important component of these patients. And as rightly pointed out already by Professor Sanjay, that there are a set of patients in whom these mutations are more likely to happen. However, we should be testing all these lung cancer patients, more often seen in adenocarcinomas and pleomorphic or carcinosarcoma patients. So the first question for the panelists is as to how do you look for these MET exon 14 splicing mutations? So let me start with Dr. Anup.
Yeah, what we do in our center is I'm working in the government sector. We do a limited NGS based assay. Mostly it is DNA based.
Mm-hmm. Okay, so you are saying DNA based NGS is what you resort to, right?
Yeah.
And what has been the frequency that you could, share with us as regards the MET exon 14 mutations?
Um,
How often are you able to pick up,
yeah.
this biomarker based on the DNA NGS?
Yeah. So far, I have six patients who treated with the MET inhibitors.
Okay. Dr. Nandini, what has been your experience? Which is the test that you advise for these patients?
So we have an in-house NGS which has both DNA and RNA NGS that detects the MET exon 14 skip mutation. So that is if it's send it in-house, and even outside we send it, if we send it to outside lab. So it's usually a NGS which has both the DNA and RNA components. Which is
Okay. And Dr. Ullas at Rajiv Gandhi Cancer Institute, what do you practice?
Same as what Dr. Nandini said, we do NGS for all the patients, including both a DNA and RNA based NGS. And that is how we detect the MET exon 14. And the incidence is approximately around 4 to 5%.
Right. So, Professor Sanjay, do all your patients undergo both DNA and RNA based NGS? 100% of the
They
times?
do.
Yeah.
Yeah, they do. I mean, our standard workflow is for all our diagnostic patients to have both DNA and RNA. But the challenge that we have is RNA NGS is really very fickle. You need to have, very good quality fixed material for RNA NGS to work. So the biggest challenge that we have is, whilst we have it available, are the samples in good enough quality for it to work? And that's why we have to have a discussion with our pathology colleagues and our diagnostic colleagues to make sure that the path lab has not overfixed the material to really allow the RNA to work. We also have a ctDNA program as well. So many of our patients get ctDNA, and sometimes we pick it up on ctDNA because many of the providers have reasonable coverage within the intron exon boundary to pick up MET14 on ctDNA.
Right. So, as of July 2024, are you adding FISH test also or not yet?
So the FISH we use for MET amplification, and we only would request the FISH if we are specifically looking for MET amplification, which we do in the certain setting of EGFR or kinase inhibitor acquired resistance.
Post-TKI progression.
Post-TKI rather than upfront.
Yes.
If we validate our NGS pipeline for amplification, so I'm quite confident that the NGS pipeline is adequate, but we generally do the FISH at the same time.
Right. Dr. Ullas, you wanted to say something.
Yeah, I wanted to ask Dr. Popat, you had a paper in ESMO 2023 about liquid and tissue biopsy concordance. So I wanted to know your results about liquid and tissue biopsy concordance for MET exon 14.
We'll come to that in the next question. Yeah, just give me a moment. Yeah. So we all agreed that we need both DNA and RNA NGS for best yield. And now coming to your question, Dr. Ullas, tissue and liquid biopsy. So what do you do? Let me ask with you, what's your practice like?
So we don't send liquid biopsy for everyone. We do send tissue biopsy NGS for everyone. Liquid biopsy only in a very, very few selected patients. We don't send liquid biopsy for everyone.
Right. Dr. Nandini?
I agree, ma'am. We usually send tissue biopsies for most patients, except in certain scenarios where we are not able to do a rebiopsy, or the patient has like inadequate tissue and or the tissue NGS fails. That's usually when we send at upfront diagnosis or at progression, where we can't get a good tissue biopsy done.
Right. And Dr. Anup?
Yeah, I don't send
So tissue biopsy.
No, liquid biopsy.
Yeah, most of us do.
Yeah, only when there is a difficulty to get the tissue.
So, Professor Sanjay, do you send both of them in all the patients or some of the patients? And there must be a subset wherein it's impossible or very difficult to procure tissue, and therefore you would resort only to liquid biopsy. So what is it like?
Yeah, I mean, we do different things depending on who's paying and what sector they're in and what the clinical scenario is. So, of course, on acquired resistance, and if coverage is okay, liquid biopsy is good to get. But actually, liquid biopsy is only useful if it tells you what it's found. If it doesn't find anything, it doesn't tell you it's not there. So you still need to end up following up with tissue. And these days, to be honest with you, we do both in parallel, because often the nature of the histology can change with kinase inhibitors. In England, we've got a large diagnostic ctDNA program. So when patients are diagnosed, the respiratory physicians and their nurses will organize a ctDNA NGS, either using Foundation or Guardant, which the government actually funds at time of diagnosis. And if that finds a tier 1 driver, you don't need then the NGS because you found your molecular driver. If that doesn't find a driver, then you then immediately reflex to tissue NGS. So that's the current status. And of course, in the middle of all of that, we've got to figure out where we're doing met fish, but we generally reserve met fish for acquired resistance.
So, like, if you have to, like, is there a subset wherein you would order both simultaneously? Like, would the yield be more if you add liquid to tissue?
Yeah, definitely. And the question is about generally an economic question, right? If economics wasn't in the setting, and if I had lung cancer, I would want both, right, liquid and tissue, because in our data set in European Journal, when you do both liquid and tissue, 25% of the time your tier 1 driver will be missed by tissue and picked up by liquid, and 25% of the time it will be missed by liquid but picked up by tissue. So really both are complementary. The question is, how do you employ that workflow to make it an economic argument for your patients and to also minimize any additional burden to your patients as well? And I think we're all struggling with that globally, but definitely both are complementary. Both have false positives, both have false negatives, but we have to be very careful about the false negatives.
Right. So as for other, biomarkers, even here, for even MET exon 14 mutation, both are complementary and they add on to the information that we get from either of them alone. Right. So very true. So DNA versus RNA-based testing, and as Professor Sanjay did mention, as to the basic difference in both of these methodologies, and we would prefer to resort to both DNA and RNA. However, there are some issues with RNA analysis, as already pointed out. But most of us now wish to, at least we are convinced that, if we use both, then obviously the chances of picking it up are much higher. So what about liquid biopsy? So we have already discussed this, and we'll move on, and we agree that both are complementary, even for MET exon 14. So let's move on. This is the data, the phase 2 vision study on tepotinib that Dr. Sanjay talked about. And this is the one which got tepotinib its approval, initially accelerated approval in 2021, and now this year itself traditional US FDA approval. In vision study also, there were both these tissue biopsy as well as liquid by Guardant, which was done. And this is the only clinical trial for a MET tyrosine kinase inhibitor to prospectively enroll patients based on the liquid biopsy. So now coming to the management question. So what are the recommendations of the panel as regards the management of these patients in whom you find MET exon 14 skipping alteration, which is the drug that you use? Then we'll come to this case scenario also. Let me hear first from the panelists. Dr. Nandini, you could take this first.
So ma'am, it's a little bit challenging to get a MET inhibitor because many of our patients are from resource constraint. But if there is a choice, we do prefer a MET inhibitor in the first line. Tepotinib we have used for many patients, and now some patients have also received capmatinib. So in those whom we can access and who can afford, we use the first line MET inhibitor preference. Of course, there are many whom we can't, and then we give them chemotherapy.
Right. Dr. Anoop, is that your practice too?
Yeah, thing is that I am a part of a clinical trial for capmatinib in India.
Mm-hmm.
So most of my patients who are detected exon 14 skipping mutations are naturally going to the clinical trial with capmatinib. That's a phase 4 clinical trial. Then some of the patients who are not interested in entering the trial, I have had tepotinib. I have given tepotinib also.
Okay. And Dr. Ullas, which is your preferred agent?
Any MET TKI which is 1 rupee cheaper.
One. So
So
you would
any
just
MET
take
TKI.
that cost into consideration, or aren't you convinced with the matched adjusted indirect comparison that Dr. Sanjay showed?
So data is good, and if the drug is cheaper, it is icing on the cake.
Okay,
But
but
I
you are
honestly
happy to
feel that
use either of those two agents?
the absence of a direct head-to-head, as what Dr.
Comparison.
also said, it's difficult to say. There are pros and cons. They're both decent drugs, but I'll be happy to use both. I mean, whatever I have more experience, whichever is 1 rupee cheaper, I tell both the companies. But I will not use chemotherapy. I will not use immunotherapy. This much I'm very sure.
So you will wait for the result of
Yes,
the
we
report of
always
the NGS and only then proceed.
I
Okay, so
never
you are
start
saying,
immunotherapy.
yeah.
Yes, I never start immunotherapy without the NGS report. I burnt my fingers, arms, legs, everyone in starting immunotherapies without NGS report. So, and I pressurize my pathologist to give me the reports. I send my resident to them every 2 days. Ki jaldi get the report faster, get the report faster. That's what I do.
So in a case like this, which is displayed here, with the advanced lung cancer, with, this PDL1 report, more than 50% reaching you in 3 days' time, you would not act on this and proceed with immunotherapy. That's what you are saying?
What I normally do is I look at the patient. If the patient can wait, let them wait. If they can't wait, I start them on first cycle of chemotherapy. We wait for the NGS report. Second cycle onwards, we add immunotherapy or switch over to NGS, depending on the NGS report.
Right. So is that your practice too, Dr. Nandini and Dr. Anu?
Yes, ma'am. Completely agree.
Yeah.
Symptomatic patients, we might consider chemotherapy before the NGS, but not immuno. And then accordingly, once the NGS, we plan the final.
So
Yeah.
I feel that in my practice, most of the patient dictated with MET exon 14 skipping, it's elderly, and most of the patients are not sick. They're manageable. They can be waited for NGS report.
Right. So you would wait for the NGS report and then proceed. Dr. Sanjay, you did talk about this and you showed that the IO, if used in such a case, would have very small response rate. 17% is the figure that you reported. And it's not at all a good idea to use IO, either alone or with chemo. If the patient is highly symptomatic, is chemo what you resort to?
Yeah, definitely. So as Ullas has said, if the patient can't wait, we give them a cycle of platinum pemetrexed, and then switch depending on what the NGS report is, either add in the pembro or NGS directed approach technique. But first line IO by itself is a disaster.
Right. And you would consider it in second or third line, as you mentioned in your talk, right?
And I think, at that stage, then, you've got other options to think about. You have to think more carefully about what the patient's fit for, etc. But, first line, it has to be a MET inhibitor, absolutely.
Right. So we have this together study as well, talking about some real world PFS, trying to compare what was reported about tepotinib in the VISION study and comparing it with either IO monotherapy or IO with chemo. And you can see the stark difference in the progression-free survival in both treatment-naive patients and later on. So we know the limitations of IO now, coming to the comparison, we have dealt with this briefly, and this was shown by Professor Sanjay as well, wherein tepotinib does seem to be a better choice compared to capmatinib based on this indirect comparison, though. But as Dr. Ullas mentioned, he would consider cost definitely in this decision making. As per this indirect comparison, both in treatment-naive patients and previously treated patients, tepotinib did produce superior not only overall response rates, but also better duration of response. So, Dr. Sanjay, what's your choice? What's your take on this in terms of the choice of MET inhibitor?
Well, look, I mean, I think it has to be a MET-specific inhibitor. I mean, I take Ullas's point on economics, right? But if you have a choice, I wouldn't use crizotinib as my first agent of choice. It would have to be either tepotinib or capmatinib. Both are very, very highly active drugs, highly active in the brain, very similar adverse event profile, very similar activity. The MAIC is interesting to know, and it may drive some of the decision making, but at the end of the day, it is very much driven by resources, economics, and what you have available. We have no head-to-head data. We're not ever going to have any head-to-head data. So I think we have to just read into the MAIC with all of the biases that these things have and make our own individual decisions as to what is the right drug for that patient.
Right, fully agreed there. And
just one point, just to clarify, I just any MET TKI means either capmatinib or
selective
no,
MET inhibitor.
yeah, no crizotinib.
Yeah, that's non-selective. So that's what he said. Yeah, he won't choose crizotinib. So intracranial efficacy also for tepotinib seems to be impressive. 88% response rates and 68% in untreated brain mets, as he showed. So that's impressive. Any panelist would like to share his or her experience in regards to the intracranial efficacy of tepotinib?
Yes,
Dr. Ullas, yes.
In fact, we had a patient whom we gave, this patient has got two particular things. Initially, we were planning to take him for one of the clinical trials where it was a MET amplified. It was IO plus TKI, IO plus MET inhibitor. But just on the last day, the trial got closed because of that safety data committee. We gave him IO and chemo to start with. The guy had leptomeningeal mets, CSF proven. And then we sent a liquid biopsy, a Guardant, and that came as positive for MET exon 14 splicing. We gave him tepotinib, and even the leptomeningeal mets had responded beautifully. The patient lived for approximately around 12 to 14 months after that. So very, very interesting efficacy on that, actually, and reasonably good. So if a patient is asymptomatic, is not really in some kind of emergency, I have convinced my radiation oncology colleagues that we will do an MRI in 3 months' time. And we'll start with the MET TKI and then try to avoid RT as much as we can.
And you did not obviously use the intrathecal methotrexate also.
We didn't. It was only yes.
Yeah, right. So that's quite impressive, especially in leptomeningeal disease, which is CSF proven. So we do believe in the intracranial efficacy of tepotinib based on the data that Professor Sanjay also showed. And now coming last to the question of safety. And this slide was also shown. So would like to hear from the panelists now as to their experience as regards the fluid retention and rise in creatinine and other aspects of the toxicity issues. Dr. Anup, what has been your experience?
Yeah, and all my patients had peripheral edema, and one patient had rise in creatinine. But all these side effects are manageable, and I see it's a very safety drug.
So did you need to reduce the dose or discontinue tepotinib because of this? No, never.
No.
Oh. Dr. Nandini, what has been your...
Peripheral edema definitely is a challenge. It's some of the patients we've seen coming as early as 2 weeks and patients getting like quite disturbed. But I mean, most of the time we just have to reassure them, and it's usually manageable. But I had one patient who was an elderly patient on tepotinib. He had underlying coronary artery disease. He had significant edema, including his upper limbs, which was swollen up to the shoulders, and because of which he had difficulty in walking. So this was one patient which there was a significant interference with activities of daily living. But most of the others, though it is, I mean, the edema is there, it does not really impact them so negatively. So like both experiences, one with the significant edema and causing issues, and the patient had drop in EF also, which was probably unrelated. He had underlying heart disease, but then we had to give him a treatment break, and then go ahead. But most of the other patients just have the edema, they complain, but they are okay with it.
Dr. Ullas, how do you manage this side effect?
I have not yet been able to master it. So there are two toxicities. One I call as a paper toxicity, that is creatinine increase. And the other which I call as paper weight toxicity, which is basically the weight gain, this thing. Weight gain, I have tried reducing dose. I have tried them salt restrictions. I have told them I have tried Lasix. I have tried steroids. Doesn't really work, because the best thing is I tell them to do exercise. Like the same thing with lorlatinib, reduce their salt intake from starting if they haven't counseled them properly. But nothing really seems to work once it sets in. The good thing is it is not as bad as what we see with lorlatinib. Lorlatinib, we see like a, let's say 20 kg, 15 kg weight raise. In this, it's somewhere around, 4 to 6 kgs. But once it sets in, it doesn't really progress after that. But not really been able to get it back to normal one. Would love to hear Dr. Popat's view on that.
Yeah, sure.
Yeah, I mean, I think I agree with colleagues. It doesn't happen in everyone. If it starts, it's generally not that early. It's a bit later on, 3 months down the line. You have to tell patients about it and their caregivers, otherwise they'll start freaking out when it happens. So that's the first bit of advice. It's a greater risk in the older the patient, so we tend to see less of it in the younger patients. Lasix can have some benefit in some patients, and some patients it doesn't work. We sometimes do strapping with the lymphedema services. That sometimes helps, sometimes it doesn't help. It's in fact sometimes more painful. We've had some very severe cases. I've often bring in on my patients for forced alkaline diuresis with human albumin solution and Lasix. That can sometimes help, but it just reoccurs because their albumin drops again in a few weeks' time. But in severe cases, we've had to do that, and that has worked. Personally, we follow the product insert package, which is dose reduction. But to be honest with you, I've never found the dose reduction particularly very useful. It either happens or it doesn't. So often we find we just re-escalate the dose again anyway, just to make sure we're getting maximum cancer coverage.
Right.
Madam, I had one patient who started on capmatinib, had severe fatigue. Fatigue was grade 3 fatigue, and I had to stop drug, and patient was restarted with chemotherapy, and patient
Had to
expired
discontinue
after
because
6
of that,
months.
right.
Yeah, severe fatigue. I don't know how. Any experience, sir? Popat, sir?
Reported, as far as I know, significant fatigue is a very well-known side effect of MET TKIs. So
I've never found the fatigue personally to be a major issue. We've had a few patients where nausea has been problematic, but not fatigue.
right. So coming to the dosing, so we know that tepotinib is once a day, capmatinib is twice daily. So is that also, a point that you would consider, Dr. Ullas?
Yeah, obviously. I mean, once a day dosage is always good. But a cheap dosage is always very good. So anything else is icing on the cake. Economics takes preference over this. But yes, once a daily dosage, a patient's compliance is actually improved.
Yeah. So it seems that, there are many pointers in favor of tepotinib, including the convenience of once a day dosing schedule. So I would end my panel discussion here. Thank you, Dr. Sanjay, Dr. Ullas, Dr. Nandini, and Dr. Anup for your contribution. And thank you. Back to the organizers.
Thank you.
Thank you so much, ma'am. And may I please invite Professor Sanjay Popat, sir, for his second lecture on management of patients with MET amplifications. Sir, over to you, please.
Great. I'm going to share the screen at my end as well. So talking about MET amp, let me know when that comes through.
So we can see your screen. Thank you.
Okay. So you've seen my disclosures. And so we're talking about MET amplification now. And, we talked about licensed drugs and the genomic aberrations. You will see here that MET amplification is not on this list. Why is that? Because from a regulatory viewpoint, MET amplification does not have regulatory approval. That's because the data that we have on it is a bit thinner than we have with MET14. That reflects some of the complexities in defining the population and also the rarity of the population as well. So when we look at the different types of MET abnormalities that we see, MET amplification is what we're talking about in this section of the discussion. Now that means you have got an increased number of copies of the gene, which usually means you have increased number of protein molecules at the cell surface, which usually means you then have increased expression. But as we know, that's not always the case, and there's not necessarily a true relationship between amplification and overexpression. Things become very complex here. Now, remember I said at the beginning of my presentation, chromosome 7 is really important because we have EGFR, CDK6, MET, and BRAF, and we're talking about MET amplification. So what does that mean? Well, there could be two different patterns of amplification. Something called focal amplification, where you have normal copies of all the other genes, but just MET itself has an increased copy number. Or you can have lots of copies of MET together with lots of copies of all the other genes. And that is also classified as MET amplification, but not really. I would call it MET copy number gain, otherwise known as polysomy or aneuploidy. And you have to know what the difference between the two is, because we think that MET amplification behaves slightly differently to MET polysomy. In fact, one of the first cases I came across was on the ctDNA NGS, and I had a case, and it's MET amplified. I was looking at the report, and it said BRAF amplification as well. And they also said MET amplification on the report, EGFR amplification on the report. I thought, hang on, this is crazy. So I spoke to the lab and said, look, this is not amplification at EGFR, MET, and BRAF. All it is polysomy, so increased copies of all of these on ctDNA. So you have to be very careful in how we are testing. So we've recognized that MET amplification can also occur on the background of MET14 and MET overexpression. So we have to be very, 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 very clear that when we are saying MET amplification, we're talking about MET wild-type amplification and not MET amplification in the setting of MET exon 14, because they are quite different. And here, really, we're talking about MET wild-type amplification. So how do we test for that? Well, the gold standard is by FISH, and this is why it becomes very complex. I always tell the residents, don't say to me the patient is MET positive. I need to know what you mean by MET positivity. Is it amplification or wild-type amplification of MET14? So generally, what we're using is FISH. So what we use with FISH is two probes. We use a green probe to look at the centromere of chromosome 7, and we also use a red probe to look at the MET gene. And what we can see is in the left-hand panel A, we're seeing lots of the red MET dots, and we're seeing only small numbers. We should only have 2 copies of chromosome 7 at the centromere. So you can see in panel A, lots and lots of red, not very much green. That's true MET amplification. On the right-hand side, we're seeing lots of green, lots of centromere 7, which means there's lots of chromosome 7, and lots of red, lots of 7. So that, all that means is you've got polysomy or copy number gain. That isn't necessarily the same thing here. So you're going to say to me, but FISH is a pain, and I have to cause extra cost. I can get everything I need from NGS. Well, can you really? Well, you have to ask your lab, have they validated copy number gain and amplification for MET against FISH? Because some labs have, but the vast majority haven't. Maybe your lab has, that's very good. But if you don't ask your lab, you don't know the answer to that question. So therefore, if you find NGS positive for copy number gain, is it a true positive or is it a false positive? And if you find it by FISH and not by NGS, is it false negative? That's the question. On the right-hand panel, we've got really good data from China, comparing patients treated with MET selective inhibitors. In the first set of bar graphs, they're all FISH. They're all tested for FISH. And if they're MET amplified in red, the response rate is high. And if they're not MET amplified in blue by FISH, the response rate is low. So FISH is really good at discriminating between who's MET amplified and responds to the drug and who's not MET amplified, doesn't respond to the drug. And in the right-hand side, you've got MET amplified by NGS, which means you do have a response, slightly lower, but you do have a response. But if you're MET negative, you still have a response. This is false negative by NGS in blue on the right-hand side. So essentially, you can be MET amplified, but not detected on NGS. So your NGS is not necessarily brilliant because you can give you false negatives in NGS, whereas FISH is the gold standard. You have to make sure that your NGS really is validated so that if you're NGS negative, it's a true negative because you're going to have subclonal amplification, which is missed by NGS. The other way it's also thought about is by immunohistochemistry. And this is one data set from a savolitinib data set where all patients who are progressing on osimertinib were tested and tested by FISH or IHC. And depending on what cutoff you use, whether it's IHC more than 90% 3+, or FISH more than 10 copies, you can then have different subpopulations. And there's overlap between the IHC positive, FISH positive group, the IHC positive group only, but FISH negative, and the FISH positive group, but the IHC negative group. So we have to be really very careful. What is the biomarker that we're testing, and how is that information going to be useful for you in the lab? So how do we test for it? What's the frequency? Well, the problem that we have with MET-amp is that different labs and different data sets have done it differently. So here, whole exome sequencing identifying it at 5.2%. FISH at copy number more than 5, identifying at 11%. qPCR more than 3, 5.6%. MET compared to SEP7 ratio more than 5, 1%. So different labs, different frequencies, different trials. And that's why we have no regulatory approval at the moment, because the whole field is in a bit of a mess. So where am I going to find MET amplification? Well, the commonest area we're going to find it is an off-target acquired resistance mutation, because this is classically what we see as a pharmacodynamic acquired resistance mechanism, where we're not changing the particular mutation, we're seeing increased copy numbers occur. And for example, when we look at resistance mechanisms of osimertinib, we see MET amplification occurring anywhere between 7%, some studies 15%, some studies up to 30%, depending on the technology that they're using. The issue is that resistance tends to be subclonal and heterogeneous between metastases. So often it may be there, but you're not picking it up. And FISH is actually really quite good at picking up these small subclonal amplification events, which might be missed on NGS. We also see it in acquired ALK resistance as well, not just EGFR resistance, particularly with lorlatinib resistance, where it's very well identified in patients. And this is data from colleagues led by MSKCC and Memorial. Now we have data on MET amplification. I told you that I led the R&D crizotinib in the National UK Lung Matrix trial, and we presented these data and published in Nature on MET amplification with crizotinib. Very low levels of activity, really median PFS less than 6 months, disease control rates less than 20%, response rates less than 10%. And that's because the majority of these patients that went into this are not de novo MET amplified, but acquired resistance. And so you've got a heterogeneous thing going on, where you've got the MET amplification together with the parent gene still needing to be drugged in parallel. Do we have any data? So this is the VISION cohort B, patients with high-level MET amp without MET exon 14 by liquid biopsy, not any other oncogene addiction, treated with tepotinib 500 milligrams once daily, response rate. And this was MET amp detection using ctDNA, NGS, Garden 360. And you can argue whether this is really truly reflective of NGS or not. They have done some correlative studies to say that it does correlate well with copy number gain more than 2.5 in plasma. And what Vision Cohort B did demonstrate is a response rate of 41%, higher in first-line therapy, 71%, lower in second and third-line therapies, with reasonable response rates, as you can see in the waterfall plot. But you know, where I tend to use it more is in the acquired resistance setting. Insight 2 data set is really the data set which looked at patients with EGFR mutant disease progressing on osimertinib, who either allocated to receive TEPO with osimertinib or only TEPO monotherapy. And they had to be MET-amp centrally confirmed by tissue or liquid. And what were the data that they used? So they had to be MET amplification, which had to be FISH positive, copy number gain absolutely at 5 or more, or amplified with a ratio according to chromosome 7 of 2. So important you remember that. Has to be the ratio of 2 or more, or copy number gain solitary by more than 5. They could have had liquid biopsy by Archer. And in the right-hand panel, you can see there is strong overlap between tissue biopsy and liquid biopsy. Now, what do they show? The important thing is on the right-hand panel, what they show is TEPO monotherapy in the acquired resistance setting is not very good. Because you need that ongoing drugging of the parent oncogene to really drug both the areas with acquired resistance and non-acquired resistance, because acquired resistance is subclonal. So you need both drugs, not just the one drug. TEPO monotherapy is not very good, reflecting our experience with crizotinib. However, when you combine it with the osimertinib, you do get very good response rates, around 50%. With duration of response, can be more than 50% ongoing for 9 months or more. This is a patient with a very young patient, 29-year-old patient, variant 3 EML4 ALK positive, progressed on first-line alectinib, progressed on second-line lorlatinib. You can see in the left-hand panel she has a hilar node and has retroperitoneal nodes. We biopsied those retroperitoneal nodes, true amplification, more than 5 copies compared to the ratio of 1 for centromere 7. Switched her over. We couldn't access tepotinib in that setting. We switched her over to crizotinib, which is a MET inhibitor. You can see in the middle panel, retroperitoneal nodes all switch off, as does her hilar node, but that's the left hilar node, but the right hilar node, which we haven't biopsied, starts to relapse, telling me that the right hilar node is still ALK sensitive to lorlatinib, but it's not MET sensitive. So we then go back and add in the lorlatinib, and you can see it results in a complete response. That was only short-lived for 3 months before the patient then had widespread relapse and need to switch over to chemotherapy. But here's an excellent case. This is a case of first-line afatinib, progressed, second-line osimertinib with T790M, very long durable response with osimertinib, progressed, ctDNA confirmed, high-level MET amplification, confirmed on tissue biopsy, widespread bone involvement, added in tepotinib to the osimertinib, complete response in the PET-CT in 3 months' time in November. Ongoing beautiful response, superb symptomatic improvement. Now, June 2024, majority of disease, still excellent response, has now a little bit of oligoprogression in the pubic bone, is having stereotactic radiotherapy and ongoing tepotinib osimertinib. So in conclusion, MET amplification detection is complex, multiple criteria. The Insight 2 criteria, which is what I use, is MET7 ratio of 2 or more. Well, you can use absolute copy number of more than 5, but I prefer there to be absolute ratio of 2 or more. You can use ctDNA, it's not very well validated. Tissue NGS is ideal with FISH, to be honest with you. You can use MET amplification as a driver, but it's unlicensed and modest supportive data. MET amplification as acquired resistance is really where we're using it. An Insight 2 data set is really where we have the majority of the data. And with that, I'd like to thank you for your attention.
Thank you, Dr. Popat. And Harshveet, can I have the control for my slides?
Yes, sir. You can please do it.
And I think it is almost dinner time in India, and we have a hungry wives and hungry husbands there and hungry kids. So I will like to stop in probably 10 minutes time. But before that, Dr. Popat, I don't think you should ever retire. But whenever you retire, I think you should have a YouTube channel and you should have your videos and you should take classes because MET amplification was never made more simpler by other than you explaining this. And one more point I would like to tell you is I think you are on Twitter and you presented the mesothelioma beat study. And there was a comment on that, if not for Dr. Popat's very dynamic presentation, the study would have been an abject failure. So that's just a kudos to you. So fantastic. Okay, but let's just come back to MET amplification. And as Dr. Popat has very rightly said, there could be primary, primary MET amplification. There could be secondary. So Dr. Jyoti, you asked us, what do we do? Now tell me, what do you do? Do you test for MET amplification in your first line or second line?
So I tested in second line, like post TKI progression, not in first line, because currently it's labeled as emerging biomarker, and it's not, proven US FDA approved biomarker to be tested for first line treatment decision making.
Correct. So Dr. Anup, first line, second line? Dr. Anup, you're muted.
Yeah, post EGFR progression,
But first line you don't.
Yeah.
Okay, Nandini?
So specifically second line, but many times, our NGS includes we can detect MET amplification. We have a common panel. So sometimes we do get a few cases with MET amplified.
So your NGS, your NGS does have a panel to detect, because our NGS, what they use in the first line, the smart panel, what we call it, doesn't really pick up the gene copy number. I'm going to come to it. Dr. Popat, what do you do? Do you specifically look in the first line itself?
Well, we get it for free because it's part, our panel will give copy number information and we validate it against FISH. So we know it's true, but as Dr. Jyoti says, it's not a validated biomarker in the frontline setting, so I ignore that information. And I only use that information on a retest in the acquired resistance setting.
So can I ask you, do you have the same panel for primary detection of this thing and at resistance also?
Yeah.
Okay, because in our setup, what we have done is, I'm going to do to you, Dr. Jyoti, because the primary, HER2 amplifications and fusions are rare. For our primary thing, we have made a very smart panel of DNA RNA, the hotspot panel. But when it comes to resistance, since we don't know what we are looking at, we use a white-based panel. Yes, Dr. Jyoti.
So I was saying that just in case the NGS reports it, then we
I will come to that.
And to confirm.
I will also come to that.
Yeah.
So let me ask you only, Dr. Jyoti, just in case tomorrow morning you have a very hi-fi patient coming from Nitesh Rohtagi to you, Gurgaon, you guys stay very close. How will you test for MET amplification, pre or post?
So post TKI progression, as of current guidelines, as I said, unless the NGS happens to report it, and I would confirm that with FISH. And we know that FISH, as Dr. Sanjay also showed, is the gold standard. We would obviously, since we are going to offer MET TKI, the decision should be based on FISH report rather than anything else, because then we are more sure of it working or not working, both ways. So,
okay, Nandini, what do you do post a TKI?
So if there is a post TKI failure, we try to send NGS for almost all our patients, and then if it is detected, we confirm by FISH, and then accordingly.
So that's what. So if you have a gene copy, increase gene copy number on NGS, you do confirm by FISH. You don't only act on that. So the question over here is, has your lab validated the gene copy number? Nandini? Your lab, what is the gene copy number increase that your lab has taken, and have they validated? Or you still confirm everything which is high GCN by CGN by FISH?
So we do confirm, so that FISH.
You do confirm. Dr. Popat, so people who have not validated their NGS should always confirm by fish. Is that what we're getting at?
Yeah, I mean, I think so, right? Because I think the real amplification is when you have true amplification, not just polysomy, right? Polysomy is not really that druggable according to the data that we have at the moment. So it's important that the NGS can differentiate between those two. And that's really where the beauty of fish comes in, because fish will tell you that. But also, the problem that we have is we have false negatives with NGS, right? And you're then missing an opportunity to drug fish.
So do you ask us, do you suggest us to incorporate fish for MET for everyone who is kind of progressing on a TKI?
Yeah, if you have an osimertinib resistance, you have to do DNA NGS, RNA NGS, and also MedFish.
That is what we do just to save money. Economics is an issue. I do the same panel for that, and I send a separate MET amplification by fish. That saves a lot of money for us, It saves a hell lot of money.
Save even more if you send it to a lab that has validated it against fish, and then you don't need to send the fish because you've got confidence in your pipeline with your NGS copy number.
Correct. So that brings me, Dr. Nandini. How do you define what happens in your lab? How do they report? I mean, this gene copy number gain or MET enumeration lab number, they are very confusing. Dr. Popat wrote a very fantastic slide about that. But how do you define? Is there a number more than 5, more than 10? What is the right number? Has your lab validated it, or what is your thing?
Our lab considers more than 10. But there have been multiple different definitions of the copy number depending on various studies and different tests used. So, I mean, universally also the exact copy number has not been the same in various settings in resistance as well as in other studies.
Okay, Dr. Anup? Dr. Anup, I think his video has an issue. Dr. Jyoti? Which one will you, which one you think is more apt, met by CEP7 ratio, GCN, or for you, both of them are same? It's just the way your lab report.
That, there is no consensus as regards the cutoffs, but I may resort to, since I'm going to use the Insight 2 study data, so I may resort to using those cutoffs only, namely 5 and 2. So as Dr. Sanjay mentioned, that's what I think he's also using. So I may end up using.
Professor Sanjay, I mean, what do you feel? I mean, one word from your side, what do you use in your clinic?
Yeah, we use against copy number, and generally more than 2 is fine because that's what the Insight 2 criteria used.
Okay, so you take a trial, use the criteria, and go ahead with that. So there is no obviously consensus on that, but that's the most important thing. Dr. Anup, I mean, this is where we are going to come to. This is the crunch of the situation. Let's say somebody has done a NGS and it has reported either a MET amplification or a MET gene copy number more than 10. PDL1 is 75%. Patient is a smoker. What would you choose? So MET amplification, CGN, let's say 12, PDL1 70%, smoker. Your choice of treatment would be a immunotherapy, immuno plus chemotherapy, or since tepotinib is now cheaper also, tepotinib.
Yeah, I will go for tepotinib.
You will go for tepotinib. Fantastic. Nandini.
I would confirm it by fish, and then if it is really amplified, then probably go ahead with the MET inhibitor like tepotinib, capatinib, whatever is feasible at that time.
Okay. Fantastic. Dr. Jyoti?
I would agree with Nandini. Like if it's fish confirmed, then yes, would talk to the patient, and then, definitely offer a MET inhibitor.
Discuss that. Dr. Popat?
So this is the acquired resistance setting or de novo?
No, primary resistance setting.
So I don't think we've got strong data on this, and I have to say I don't give MET inhibitors frontline. I don't think the data is strong enough for this as yet, even if it's confirmed by fish, and I would treat according to standard guidelines, according to chemo or chemo-IO.
I think I would agree with Dr. Popat. I mean, what I would do is probably I'll get an IO plus chemo, even if it's PDL1 more than 70%, just to, just to probably guard my own insecurities regarding this be a bad prognostic marker. So I would probably in a first line with the tepotinib is something where the data is very sketchy, I believe. Although the Vision B cohort B trial did show the data, but if you look over here, very, very small numbers, 7, 11, 6. Having said that, the overall response rate was higher in the first one, but the numbers are very, very small. So first line, I would probably want to go ahead and give immuno plus minus chemo, and then probably go ahead with a tepotinib. However, I will discuss if the patient does not want immunotherapy, chemotherapy, or there is an issue, I'll be absolutely happy in giving tepotinib. There is no data for capmatinib as far as I'm concerned in this particular setting. Is it right, Dr. Jyoti or Dr. Popat?
Yeah,
I think that's right. Okay.
Yeah,
So,
I have sir, I have two patients who are not willing for chemotherapy for MET amplification. I started with the tepotinib. It's a good response with the tepotinib. Still, patient is going on tepotinib
that's
for the last 1 year.
That's fantastic. That's fantastic. But we need much more data than that, I hope, probably more. But I would like to, always discuss this option and maybe keep it in the second line when the patient does progress on this. Dr. Anup, to you too. Patient is on osimertinib, has progressed. You have done a NGS and a FISH. MET amplification is positive. What would you do?
Yeah, good question actually. So,
I think we are having some network issues. Nandini, can you answer this for me?
So that is an EGFR setting with the MET
Yes,
amplification.
Yes, it is.
So we have treated patients with
Popat,
EGFR.
when there is such
Nandini, go ahead.
Yeah. So with so we've had osimertinib resistance where we've treated with osimertinib with tepotinib for a few patients, and I know 1 or 2 are really, have had a good controlled progression-free survival of over a year. So we have used the combination of EGFR TKI with tepotinib in this setting.
Dr. Jyoti?
Yeah, I would add tepotinib and continue osimertinib.
Absolutely right. We will continue osimertinib plus tepotinib. Insight 2 is what we actually believe. In fact, I have had a patient who started on afatinib, had a T790M, osimertinib, was then taken into one of the trials in which we gave osimertinib plus MET TKI. Progress, we gave chemo. Progress, we gave some more, and then he had developed a BRAF mutation. And he now is on OC and dabrafenib trametinib. And it's been around 8 years now, and 3 markers which he has got. So that's really very heartening to see the precision medicine which has actually come over there. But I agree that only tepotinib does not really have a role. We should give osimertinib and a MET TKI over there. Intracranial brain mets, I think we did speak about that we have a good, and if the patient is asymptomatic, we should probably just give the TKIs and the patient will tolerate it fine. So MET amplification de novo. This is one new terminology I have used in this best of ASCO. MET amplification de novo. Nandini, your practice changing score on Monday out of 10.
So maybe probably think chemo plus standard
Chemo
therapy
plus
first line
TKI.
MET. Yeah,
Okay.
second
At resistance. I think one very important thing is most of us need to understand that the panels which we use in our the coupon panels which we use, they do not test for MET amplification. I think the fun thing which has just come out of this is we need to definitely check for MET amplification. Definitely ask our pathology colleagues in the second line setting after the TKI failure. Probably ask for them if you have the resources and the patient is just not willing for them in the primary setting also. After the first line setting, definitely if it's an EGFR, but maybe after lorlatinib also, you can think in terms of using a MET inhibitor because it is coming as a resistance pathway for a lot of them. First line, I would probably still hold my horses, even if it's a Merck-sponsored symposium. But I will still hold my my horses for giving tepotinib. Discuss with it in the patients who are not really willing for immunochemo. Professor Popats, your parting points, and then we can all go for dinner, at least in this part of the world.
I totally agree, and I've got nothing more to add to your wonderful conclusion. Thank you.
I think you are hungry for a tea, and Nandini has a question for you.
I just have one question. Why is it that when we use it in amplification, tepotinib is 500 milligrams, and for the exon skip, it is 450? Is there a like some kind of mechanistic reason for having a higher dose?
No, no,
It was just the type of tablet that was available at the time, the free-based versus the salt-based version.
Dr. Jyoti, any parting comments or questions before we
Fully agree
let
with
Dr.
the
Sanjay go?
conclusions that you made, fully agree with what you
Okay.
said. Yeah.
Dr. Anup, your comments? Okay.
So, so when we have a meta amplification, we should continue osimertinib along with the
Yes, we should. In the
MET
second line,
inhibitors.
yes, we should. In the second line, we should. Yes.
In the lorlatinib also, you have to continue lorlatinib plus tepotinib.
That's the sense which we are getting actually nowadays. In fact, we have an osimertinib plus edectinib. We have osimertinib plus entrectinib also now. So I think the point is to continue the primary driver mutation also. Okay. So with this,
I had
yes, Dr. Anup.
Yeah, I had one patient, exon 20 insertion plus MET exon 14 skipping mutation, was treated with chemotherapy plus crizotinib. Patient had a wonderful response, and patient still going on for the last 12 to 16 months.
Fantastic. That's so very heartening to know that people with cancer are doing so well. I mean, that's all the power of precision medicine. So with this, thank you, Professor Popat, thank you, Dr. Jyoti, Nandini, and Dr. Anu for a wonderful discussion. And maybe you can enjoy the post-election results, Professor Popat, today, and I'll not keep you away from that. Back to the organizers.
Thank you so much, Dr. Batra, sir.
Yes.
May I please invite Dr. Shyam Aggarwal, sir, for his concluding remarks?
Yeah, so I think all has been said regarding the MET exon skipping mutation and amplification. So I think the story will only begin if you have a robust testing mechanism to figure out these abnormalities. So I think, as was pointed out, that you got to have the DNA and the RNA NGS available for the exon skipping. And I think we need to incorporate the FISH test if you really want to look at the gene amplification, because you do have these potent agents which can really turn around the life of a given individual in a very positive way. And just to add, if somebody's failed osimertinib, you do have the amivantamab combination, which can be utilized, although it is expensive. But I think, as was being said, precision medicine is on a roll, and genomics is on a roll. The tissue and the liquid biopsy, I think, are definitely adding on to the numbers. So if you can afford, maybe you go for both of them so as to give the benefit in a particular patient who can afford both. But I think if you discover these driving oncogenic drivers and you give an appropriate drug, it could really change the life. So I think with this, thank you very much. It was very exciting. Thank you, Dr. Popat and Jyoti and Ullas and all the panelists for joining us, and I'll not stand between you and dinner. Thank you very much.
Thank you, sir.
Thank you so much, Dr. Aggarwal,
Yes.
Dr. Popat. Thank you so much, Dr. Jyoti Wadhwa, ma'am, Dr. Ullas Batra, sir, Dr. Nandini, and Dr. Anup. Thank you so much for the interactions today. Good night.
Right.